Hello, I'm Spencer King from Emory University in Atlanta, and my co-chair is Marie-Claude Morice from Paris.
Hello.
And we're delighted today to have on our panel Davide Capodanno, Alaide Chieffo, Tullio Palmerini, Duk-Woo and Renu Virmani. Our presentation this morning is going to be the future of PCI, contemporary optimal indication, technology, and outlook. And we're looking forward to hearing from Robert Byrne from Ireland to inform us on this subject. Robert?
Thanks, Spencer, for the kind introduction. Thanks to the organizing committee for the invitation to participate at TCT Asia Pacific 2021 and to talk on the future of PCI, contemporary optimal indication, technology, and outlook. So I'd like to dedicate this presentation to my mentor, Professor David Foley, who many of you may know and who passed away unfortunately in recent times during these difficult times that we're having. These are my disclosures in relation to grant and research support at institution of prior and current employment. So in terms of the agenda for the next 15 to 20 minutes, a brief history of catheter intervention, aware always of presenting on this topic when Spencer is in the audience, a look at drug-eluting stents as a breakthrough technology, and mentioning briefly remaining unmet need, looking at approaches to angioplasty now in terms of leaving nothing behind, a couple of words on advances in lesion preparation and complex PCI before finishing up with some lessons on indication post-ischemia. So we know that the history of catheter intervention has been marked by a series of successive innovations and improvements over the course of many decades. Grunsig building on the work of many who had gone before him in terms of diagnostic angiography, in terms of intervention in the peripheral space, culminating, of course, in his groundbreaking work in 1977. And since then, we've had important developments in terms of dual antiplatelet therapy, in terms of stents, and in terms of drug-coated devices. Andreas's work is, of course, very well known in researching the Lancet Review article in 2017. I had the pleasure of corresponding with his assistant, who provided some very interesting insights into his work, including the well-known photograph of his presentations at the American Heart Association, detailing initially his preclinical work and then subsequently his clinical work. These are the Bastel catheters, as they're known in German, or the catheters that they put together on their own table, which actually served as prototypes then for the models that were used in the first human investigations. This is the detail of the first procedure, Mr. Bachmann, who many of you may know, and he's had a very long life after this successful procedure done on the 16th of September in 1977. In the current era, it's interesting to note that pressure guidance was used in terms of defining the treatment area. The acute result was excellent, and the result proved to be durable. And anyone who's talked to Mr. Bachmann, he'll tell you the secret of his success is that he didn't take any of his medications afterwards. Stenting, I won't dwell on too long. Important advances in the first human use of stents in March, April 1986, culminating then in large-scale randomized control trial data supporting use of stenting, which became available in 1994. One area when we talk about developments in catheter technology that goes hand in hand, and we're going to discuss it in detail during today's session, is the explosion of data in relation to dual antiplatelet therapy. And this, I think it's widely agreed, has been one of the key factors in making PCI one of the most commonly performed medical procedures worldwide. So what we can learn from the early experience of catheter intervention is that the introduction of stents and of effective antiplatelet treatment agents were critical to ensure stable and reproducible results and to enable the widespread adoption of percutaneous intervention. Drug-eluting stents were certainly a breakthrough technology. We're aware of the different classes of stents which are defined by their polymer coatings, durable, biodegradable, and polymer-free. We know that early drug-eluting stents represented a significant breakthrough in terms of restenosis, in terms of reducing the risk of restenosis compared with bare metal stents. You can see this on the top right of the slide. This is a systematic review of 158 randomized trials that we did as part of the ESC stent task force in 2014-2015. And it's of course clear that the first generation of DES was a breakthrough for restenosis, but actually the new generation drug-eluting stents have also been a breakthrough for stent thrombosis, with lower rates of stent thrombosis than you saw with earlier generation stents and indeed with bare metal stents. And for this reason, since the 2018 guidelines, the recommendation for drug-eluting stents has been universally a 1A, regardless of clinical presentation, lesion type, planned non-cardiac surgery, anticipated duration of dual antiplatelet therapy, or concomitant anticoagulant therapy. So great progress with this technology. Now, we're often asked the question, is one drug-eluting stent better than another? Is one class better than another? And that's a discussion that can take some time because of the sheer volume of randomized control trial data that's available. This is just an update for an article that's in press in JACC Interventions, looking at comparison between biodegradable polymer SES, the Orsiro stent, which is in red, compared with other contemporary leading widely available stents such as the durable polymers Otorlamus eluting stent or the durable polymer Everolimus eluting stents. And I think one thing you can take home is that in unselected patients, the clinical performance of these devices is unlikely to differ substantially. In one study or the other, you can see BioFlow 5 and BioSTEMI, for example. There was some evidence that the newer biodegradable polymer DES might have superiority. Some of this difference due to differences in periprocedural myocardial infarction, which is of uncertain clinical relevance. But I think broadly speaking, we can say that when choosing a stent from those widely used and approved for clinical use in 2021, the type of polymer coating is unlikely to represent the decisive factor in its own right. And of the widely used stents, meaningful differences in terms of clinical outcome is debatable. We learned that the importance of having highly effective and safe drug-eluting stents is that we could push the boundaries of PCI, and left main stem disease is one that has been widely discussed, particularly in recent years. I think in the absence of high disease complexity outside the left main stem area, certainly this with current generation drug-eluting stents, the rate of hard clinical endpoints, death, myocardial infarction or stroke, when you compare PCI with DES against coronary artery bypass surgery, you're seeing broadly comparable results. Certainly, as you see on the right of this graph, there is some time dependency, and this is an issue of ongoing discussion and some controversy. But I think the devices that we have available to us now in contemporary PCI mean that we can confidently treat patients with left main stem disease with the options that we have. I said I'd mention unmet need, and I think there is some unmet need in relation to diabetes mellitus. We're aware that if you take the PCI versus CABG debate and look at it in the diabetes patient cohort, that in many areas of disease complexity ranging from intermediate to high, there seems to be superiority long-term with bypass surgery. This is due to a variety of factors, but one of them is the relative underperformance of drug-eluting stents in patients with diabetes. And I think this represents an unmet need. We saw it in the early experience with the everolimus eluting stent, that while there was very clear iterative improvement over the paclitaxel eluting stent in non-diabetic patients, in diabetic patients it wasn't clear. There are a number of stents which are coming to market looking to address this niche and improve drug release and efficacy in diabetic patients. But I think we can agree it's an area of somewhat unmet need at present. So high efficacy DES have facilitated the expansion of PCI to more complex disease patterns, but patients with diabetes continue to have unmet need, and dedicated stents may have a role in the future. A word or two on bioresorbable scaffolds. This is from the early experience with one of the initial device iterations. This is a 10-year follow-up, and I think we can all agree that an artery that looks like this 10 years after implantation of an intracoronary stent, that's what we want to get to, positively remodeled vessel, good vessel healing. So I think the concept intuitively makes sense. On the other side, from the mature first generation devices that we had, most noticeably with the PLLA-based stents, which were in widespread clinical use, the clinical performance in comparison with benchmark conventional stents was not as good as had been anticipated. You can see in this meta-analysis done as part of the ESC task force on bioresorbable scaffolds, we're seeing a clear increase in target lesion failure of the order of 35% or so with the scaffolds, and a more than threefold increase in device thrombosis, which is clearly not acceptable and resulted in this technology being withdrawn from market. Possible niches emerged if you look at the data in thrombotic lesions, where there was perhaps good stent expansion, lesser issues with compliance, based on smaller studies, some evidence to suggest that the performance in acute MI might be comparable to regular drug-eluting stents, an area that requires further study, no doubt. So I think we can summarize from our experience with the scaffolds that the concept behind the devices remains valid, and further iteration and clinical testing is warranted. Another approach to leaving nothing behind is drug-coated balloon angioplasty. And this is an area where we are hearing more and more, initially in the in-stent restenosis space, but now also in the de novo space. A couple of key things to bear in mind. Number one, it is a local drug delivery advice. It's a mechanism with which to deliver drug. It's not a catheter for dilating lesions. So it's the preparatory work needs to be done, and needs to be done well before a top coat is applied of medication. These balloons are fragile. They must be handled on the cath lab table very carefully. They must be introduced to the lesion with as short a dwell time in the blood and guide catheter as possible. Otherwise, they're known to be a highly inefficient way to deliver drug, and if the dwell time is long, then this further reduces the ability to get drug to where it needs to go. We know that different to stenting, we should accept a somewhat inferior result when we do drug-coated balloon angioplasty, be it for in-stent restenosis or be it for de novo disease. We have learned to accept a non-stent-like result, because when you come back and look at these lesions a number of months later, you tend to see completion of vessel healing and durable results. De novo disease is one that's gathering more attention now. When we remember about switching to stents back in the 90s, one of the area of which there was most concern was the unstable acute results due to dissection flaps. As we have got more experience over the decades, we now know that not all dissection flaps are the same, and some can be left without further stenting after dedicated balloon angioplasty. And the progress that we've made in dual antiplatelet therapy is not to be underestimated in stent-free angioplasty with drug-coated balloons. And the active coatings on the balloon then seem to address the second problem of plain old balloon angioplasty, which was restenosis a number of months following intervention. So there's good reason to believe that contemporary drug-coated balloons with contemporary dual antiplatelet therapy can be a safe and effective way to treat not just in-stent restenosis, but also de novo disease. We've made some small steps in terms of the randomized control trial data, though honestly, we don't have the same quality of data that we have with drug-eluting stents. Basket Small 2 was one of the studies that received a considerable amount of attention over the last number of years. Non-inferiority against drug-eluting stents. There were some concerns because the drug-eluting stents group contained some patients who had early generation drug-eluting stents, and we know that they had issues. 3-year data has subsequently been presented, which looks good. And I think for small vessels, a drug-coated balloon angioplasty is definitely a good option, perhaps also for patients who have high bleeding risk, and we need more studies on this in the time to come. So drug-coated balloon angioplasty shows promise in de novo lesions, but further testing is required in this specific subset of patients. One of the areas that has really facilitated the expansion of PCI to more complex disease patterns is the tools that we have in our armamentarium for complex disease, for heavily calcified disease. We've made a lot of progress in non-compliant balloons. This is the Cis Balloon, which allows balloon dilatation up to 55 atmospheres of pressure. And there are some data to suggest that at this degree of pressure, actually the calcium tends to be pulverized, and preliminary studies and randomized control trial experience with this balloon suggests that it can make an important contribution to lesion preparation. Scoring cutting balloons have also been an important part of the development. These had previously been limited by poor deliverability, but that's been addressed by the latter iterations. And we know also from randomized trials in the setting of in-stent restenosis that if you systematically prepare lesions with cutting or scoring balloon and then follow up with drug-coated balloon therapy, for example, that results are more durable. So better lesion preparation, I think, is key both to stent-free and conventional stent angioplasty. Intravascular lithotripsy, of course, has been the latest development to supplement our tools that we have, particularly for calcified lesions, and to build on the experience we have with rotational and orbital atherectomy. This is a slide looking at its treatment for in-stent restenosis, and the data that's emerging for de novo heavily calcified disease is encouraging and has led to recent approval by the Food and Drug Administration in the United States. So this is something that's becoming more and more a part of our daily practice. So improved tools for lesion preparation facilitate safer. I think it's important if the stent is well implanted, it's safer and more effective treatment of complex disease patterns. Intravascular imaging, I think, is an interesting one, and we're aware that there's quite a divergence in uptake across different geographical regions. This is a survey that we did with the APCI a couple of years back, and if you look here at panel B, you can see that green bar represents, yes, I use intravascular imaging in more than 15% of my patients, and you can see that in Asian countries this is really a universal approach for operators. But look at Europe and outside Europe and the rest of the world, we're seeing only 10 or 20% of operators say they use intravascular imaging frequently enough that it accounts for more than 15% of their caseload. We're well aware of the progress that's been made with intravascular ultrasound and also more recently with high definition intravascular ultrasound. And OCT also seems to be an important part of the intravascular imaging picture. We know that findings that we see in intravascular imaging frequently lead us to change our strategy, even when we think the stent has been well implanted angiographically. In the Illumian 1 study, 25% of patients where the operator said we're done still had actionable items. And I suppose the real question for the years to come is whether the systematic use in higher risk patients of OCT, and not just of OCT arrivus, but of specific algorithms to help the operator to maximize and optimally implant the stent, if they will deliver benefit in terms of reducing adverse clinical outcomes at long-term follow-up, is very much an open question, and something that we're seeing in Illumian 4, and hopefully we'll have an answer on that very soon. So I think detailed automatic algorithms to guide stent implantation may further improve outcomes with percutaneous intervention going forward. So to finish up, I'm going to deal with changes in indication. This is a case history of a 72-year-old gentleman who recently presented with CCS 2 to 3 angina, had HS troponin less than 14, underwent coronary angiography, and you can see he has multivessel disease, but he has a heavily calcified lesion here in the proximal to mid Alaide intravascular ultrasound, which we use regularly, shows that we have a proximal vessel size in the left main of about 4.5 millimeters. We have severe 360-degree calcium, and we have a distal reference of about 3 millimeters. And I suppose in patients who are stable and we're faced with this anatomy, one of the lessons from the Ischemia trial is that we should discuss with the patient the risks, benefits of revascularization and the modality of choice. And this should be assessed offline before a decision is made together with the patient. We know that Ischemia showed us that a invasive strategy was not superior to a conservative strategy in terms of the primary endpoint. You can see, as with PCI versus CABG for left main disease, the curves cross, so there is time dependency, and longer term follow-up is going to be important. It's well documented that rates of spontaneous myocardial infarction were reduced with the invasive first strategy, and quality of life was improved, particularly in patients with a higher symptom burden. So I think it re-emphasizes for us the importance of shared decision-making for the patient. In this case, the decision following MDT discussion and discussion with the patient was to have a straightforward PCI procedure with calcium modification and a single drug-eluting stent to improve their symptom burden. The primary findings from ischemia can be summarized as our management strategy decisions should be based on symptom burden and quality of life, the finding of reduced spontaneous MI, what the life expectancy of the patient is, and the absence of a signal of mortality difference between the groups. So shared decision-making for PCI based on symptom burden, quality of life, and risk of MI going forward. So to summarize then, the introduction of stents and effective antiplatelet treatment were critical to ensure stable and reproducible results after PCI. High efficacy DES and better techniques for lesion preparation have facilitated the expansion of PCI to more complex disease patterns, though areas of unmet clinical need do persist, particularly in relation to diabetes mellitus. The concept of scaffold therapy remains valid, and further iteration and clinical testing is warranted. Drug-coated balloon shows promise in de novo disease. I do think we're going to hear more about this in the years to come. Further clinical investigation is required. I think we're also going to hear more about automated intravascular imaging and or automated pressure wire algorithms to guide optimal stent implantation in the years to come, and shared decision making for PCI based on symptom burden, quality of life, and future risk of spontaneous MI is key in patients who have stable disease presentation and obstructive coronary artery disease. Further reading on these topics you can find in our Lancet review article from a couple of years back, and I think Byrne Meyer's excellent review of the history of angioplasty, and I think many of you will agree this is probably one of the first selfies that we've seen, which is of Andreas. Thanks for your attention.
Thank you, Robert, for that excellent presentation. Marie-Claude, do you want to introduce our next speaker?
Yeah. Yes, please. Thank you, Robert. It was incredible. Huh? Now we will hear about Deepak Bhatt. He will update us on antithrombotic therapy after ACS PCI, the recent advances and innovation in drug and strategy. Deepak, please.
Thank you once again. It really is a privilege to be able to speak with all of you today on the topic of antithrombotic therapy, and in particular after ACS and PCI, with a focus really on some more recent advances. I think that there's a lot that one could talk about in this particular field, but I'm going to focus on a few of the more recent developments. I think Dr. Byrne's overview of PCI was outstanding, and it shows the central role that antithrombotic therapy has played in allowing those advances in PCI. Before I get started, here are some disclosures, including relevant research funding disclosures paid to Brigham and Women's Hospital from AstraZeneca, Bayer, and Phase Bio that includes some research I'll be covering, also honoraria from Population Health Research Institute in Canada for my role on the COMPASS trial. So let me start first with a little bit of a discussion about platelets and their importance. Platelet activation and ultimate aggregation is really the central part of what causes thrombosis in the context of plaque rupture with acute coronary syndrome or from stent implantation. We've got Dr. Virmani on the call here today as part of this session, who's done a lot of the pivotal work in understanding the biology of what happens when stents are implanted. And surely the activation and aggregation of platelets is a big part of that. However, as interventionalists, we don't want to focus overly on just the stent implantation aspect of things. It's nicely summarized in this figure from the European Society of Cardiology out of their most recent guidelines. This term of chronic coronary syndrome has been introduced. And the real point here that I think is a fundamental one is, yes, a patient can have an ACS that can prompt all sorts of things. In the majority of cases, revascularization. The majority of those are done percutaneously. But there is a stage before that happens when we potentially could have intervened with things like diet or statin therapy or other medical therapy, including antithrombotic therapy. And likewise, after that ACS period, perhaps after that ACS plus stenting period, the patient does remain at elevated risk, and there's potentially a role for not only secondary prevention more broadly, but specifically antithrombotic therapy. The real question, controversy, debate has been what should that intensity of antithrombotic therapy be and for how long? And I'm not sure I'm going to resolve that in the next 20 minutes. But a central tenet to all of that is the Adp receptor, in particular the P2Y12 receptor, which is where the active metabolite of clopidogrel and prasugrel bind, and previously ticlopidine when that was in use. And it's also where drugs like ticagrelor and cangrelor bind, though without the need for any sort of metabolism. So a number of different ways to antagonize the Adp receptor, all of which are important. And going back a bit in time now, at this point, actually 20 years ago, it's hard to believe it's 20 years, Cure and PCI Cure were published showing the value of dual antiplatelet therapy. It's important to realize, not everyone seems to completely remember the trial, that this was essentially a comparison of a month versus a year of aspirin plus clopidogrel in patients with ACS, here specifically with ACS and PCI. And you can see the large relative and absolute risk reductions that occur. So when we're talking about subtracting therapies, it's important to realize that a very well done, well-powered trial Cure and a pre-specified subgroup of that PCI Cure both showed significant large reductions in events when the comparator is placebo. That is clopidogrel versus placebo on a background of aspirin. And again, the comparator is 1 month of DAPT versus 12 months of DAPT. Now, sure, as you heard from Dr. Byrne, things have improved dramatically with respect to PCI. Stents in particular, the current generation drug-eluting stents are really excellent. No question that rates of stent thrombosis have fallen, both due to the stent implantation technique, maybe optimal adjunctive imaging as well. But nonetheless, the majority of these events that were prevented weren't in fact stent thromboses. That was one trial. Sometimes people say, I want two. Well, there was a second trial, the Credo trial, more elective PCI, whereas PCI cure was really focused on ACS patients. These were, in some cases, stabilized ACS, but for the most part, elective, lower risk PCI. And here as well, same message, that a year of dual antiplatelet therapy versus a month of dual antiplatelet therapy resulted in a significant reduction in hard ischemic events, MI, stroke, or death. And this isn't marred with any controversy of what's an MI, how big an MI counts. You know, these are the old-fashioned definitions of MI. And in two separate trials, large relative and absolute risk reductions. Interesting that they're also similar in magnitude. So, you know, this data is old, but it is still, I think, foundational. And I'm not convinced that the fundamentals have changed other than a dramatic drop in stent thrombosis rates. But as far as the rest of the rate of ischemic events not related to the stent, I'm not sure we've made as much of a dent in it. The biggest problem with dual antiplatelet therapy is bleeding, and the most frequent form of major bleeding is GI bleeding. And the Cogent trial had shown that the addition of a proton pump inhibitor to dual antiplatelet therapy, either in the context of ACS or PCI or both, produced a pretty dramatic reduction in GI bleeding, a hazard ratio of 0.34. So essentially a third the risk of GI bleeding if one is on a PPI versus not on a PPI. So if the concern about long-term DAPT is bleeding, well, the most significant form of bleeding, or at least the most common significant form of bleeding, can be reduced, GI bleeding. All right, that was a brief history of clopidogrel. What about prasugrel? Well, that's also got a lot of great data supporting its use. It is basically a better mousetrap. That is, it is a more potent version of clopidogrel, still a prodrug, still needs to be metabolized. So still some of the theoretical disadvantages of clopidogrel, but ultimately, by the time it gets to the platelet, there's more active metabolite and therefore more antiplatelet effect. Triton-TIMI 38 examined ACS patients undergoing PCI. The overall trial was positive. This post hoc analysis, which I believe was mandated by the peer reviewers and not necessarily the investigators, from what they tell me, ended up being quite insightful. While the overall trial was positive, it's important to note that in patients with a prior stroke or TIA, in fact, the use of prasugrel instead of clopidogrel on top of aspirin was harmful. That is, there was no net clinical benefit. The bleeding outweighed any reduction in ischemic events, and that's why there's a black box warning. Don't use prasugrel in those patients. Interestingly, in patients greater than the age of 75 or below 60 kilograms, prasugrel wasn't worse than clopidogrel, but it wasn't better. And it's pretty clear now that in those subgroups, if one is going to use prasugrel after the initial loading dose of 60 milligrams, probably best to use 5 milligrams a day and not 10 milligrams a day. And more recent trials like SR Reactive told us how to use prasugrel a bit better than back in the era of Triton-TIMI 38. The challenge, though, with going from clopidogrel to prasugrel or ticagrelor is that when we intensify the degree of platelet inhibition, it's like navigating between Scylla and Charybdis, that is, being between a rock and a hard place, a very difficult proposition. For sure, increasing the duration and intensity of dual antiplatelet therapy reduces important ischemic events, stent thrombosis, which, as I mentioned, is dropping in frequency, but spontaneous MI, or at least the consequences of spontaneous MI, that is, the plaque's going to rupture, but the antiplatelet therapy is essentially a seatbelt or an airbag, hopefully preventing that plaque rupture from turning into an ST segment elevation MI, potentially a fatal one. So that's the benefits. But the bleeding, of course, is there's no way around it. It's not like statins where, yes, there's a lot of benefit, but yes, there are concerns about side effects, but in terms of really bad side effects, extremely rare. Here, it's a different story because there is the occasional intracranial or fatal bleed that may occur in the more common GI bleeding, as I mentioned. Then, of course, in the evolution of antiplatelet therapy, and trials came ticagrelor, a direct-acting ADP receptor antagonist, not requiring any sort of in vivo biotransformation, and having a reversible nature, not immediately reversible. So it doesn't help if someone's having an intracranial hemorrhage and they just got ticagrelor, but reversible in terms of its receptor binding kinetics, such that that could potentially be exploited in a number of ways. So if the drug is stopped, essentially within 3 days, it's out of the system and a patient could undergo surgery. And there's some potential other advantages of the reversible nature in terms of allowing the development of agents that reverse the action of ticagrelor. But I'll come back to that in a moment. Let me now just share with you quickly the data from Plato. In this particular trial of all comers with ACS, ticagrelor beat clopidogrel, a significant reduction over the course of a year in ischemic events. Important, much like Triton, that this wasn't a placebo-controlled trial. So if there were a placebo here, presumably the risk reductions would be even larger than this. Important to note in Plato, unlike in Triton, there was a significant reduction in cardiovascular death, about 1 in 100 patients less likely to die. So something to factor in choosing between different antiplatelet therapies. Now, for the sake of time, I'm not going to review all the long-term DAP trials, but instead share with you this meta-analysis. And this pooled data, relevant subgroup data from a variety of trials such as Pegasus, DS-Late, the DAP trial, Arctic, Prodigy, Charisma. And the bottom line was taken all together in patients with a history of ACS. The endpoint of cardiovascular death, MI, or stroke was significantly reduced, about a 22% relative risk reduction or so, about a 1.1% absolute risk reduction that was statistically significant. Now, even if we look at death from cardiovascular causes, a significant 15% relative risk reduction, in absolute terms, it is modest, a 0.3% absolute risk reduction. So this isn't like statins for ACS patients, for example. This is a much more modest risk reduction. And the bleeding is just inevitable with about a 70% relative excess and about a 0.8% absolute risk increase. So the reduction in hard MACE, ischemic events, is a little bit more than the increase in major bleeding, but the net clinical benefit just in this broad, unselected population of patients with a history of ACS is a narrow risk benefit for sure. However, we do have data from trials such as SMART-DATE that in the ACS patient, withdrawing dual antiplatelet therapy earlier than 6 months versus going, say, 12 to 24 months is associated with an excess of myocardial infarction. So the experiment has been done, and there certainly is, I think, a benefit of longer durations of DAP versus shorter ones in patients who can tolerate it that are at low bleeding risk. Now let me share with you some more recent data, such as from the THEMIS trial. And this was a trial of 19,000 patients with diabetes with a history of stable coronary atherosclerosis, no prior MI that was known, no prior stroke that was known, but known coronary artery disease. Could have been treated medically, could have been treated percutaneously, could have been treated surgically. Just had to have greater than or equal to 50% stenosis. And it actually is the largest trial ever done in diabetes, even if you're talking about trials of SGLT2 inhibitors or GLP-1 agonists. So pretty large trial and a pretty broad representation of patients. Here was the primary composite endpoint, cardiovascular death, MI, stroke, a rate of about 7.5% over an average of 3 years. Not that dissimilar from the rate if you looked at patients with prior MI without diabetes, for example. So in some respects, a higher risk population despite their stability than one might think, and a significant 10% relative risk reduction, about 0.7% absolute risk reduction that was statistically significant. So a positive trial, though obviously a rather modest benefit. And certainly there was an increase in bleeding, including major bleeding by a variety of definitions, about a 2.5-fold excess. And also, though small in absolute terms, this large sample size allowed us to see a statistically significant increase in intracranial hemorrhage as well. And I think this next point is an insightful one. The majority of those intracranial hemorrhages were traumatic subdural hematomas. So I think there's a lot of discussion, or at least I had always done it with patients that are on warfarin or NOACs to be careful, wear a helmet if they're doing things like skiing or biking. We should do that anyway, but especially if you're on the anticoagulants, don't climb ladders or do dangerous things if you're older, where you might fall. All that advice really should be given to people on dual antiplatelet therapy, because there is a small but real increase in intracranial hemorrhage. In fact, we'd seen that even when we pooled all the clopidogrel trials together. Now, discontinuation of antiplatelet therapy is an issue. It's an issue with statins and everything, but it's a bit more of an issue with antithrombotic therapy because of the usual reasons patients stop drugs plus bleeding. Interesting though, with ticagrelor, there was about a 10% excess discontinuation versus placebo. Even in the placebo arm, a quarter of the patients stopped. It just shows you how powerful the placebo or nocebo effect is. Patients are often thinking they're having side effects attributable, in fact, to just being on a placebo. But of the excess rate of discontinuation, actually with ticagrelor, about 2/3 was due to dyspnea, and only 1/3 of that was due to major bleeding problems. So a bit different than what we would have hypothesized. But at any rate, that was the excess rate of discontinuation. If we look at the patients that actually stayed on treatment and on treatment instead of intent to treat analysis, well, there the data looks a bit more robust with a 19% relative and 1.2% absolute risk reduction at a year. Still not an enormous absolute risk reduction, but does show the potential of, in more carefully selected patients here, they're sort of self-selected by being adherent, but also selected by the fact that they didn't have side effects like dyspnea or bleeding. It shows the potential benefit one can get from protracted dual antiplatelet therapy here, not in an ACS population, not in a freshly stented population, but just by virtue of having coronary artery disease. So while the magnitude of benefit is still rather modest in absolute terms, I believe it's an important proof of principle, and the first time that DAP was shown prospectively to have value in stable CAD. Themis PCI was a large pre-specified subgroup from Themis, the largest subgroup of patients with diabetes with a history of PCI to date, 11,000 patients. And here, similar to the overall trial, there were significant reductions in MI and in stroke. And importantly, even in STEMI, as was the case in the overall trial, a significant reduction. So MI and stroke both being reduced. Neutral effect on cardiovascular death, however. And in the on-treatment analyses now, again, a best case scenario, a bit of a selective, perhaps biased way of looking at data, a best case scenario way of looking at data. Here we see, even for all-cause death in those patients with a history of PCI, a significant reduction in that endpoint, with the caveats of looking at isolated secondary endpoints in subgroups. Another important insight from Themis and Themis PCI had to do with the benefit of ticagrelor versus placebo on a background of aspirin as a function of time between the PCI and the randomization. And what I think is insightful and interesting here is that if we go out to 10 years after that initial PCI, there is still a detectable benefit of ticagrelor versus placebo. In fact, statistically significant, that is the 95% confidence interval, is the dotted lines not crossing unity out to about 6 or 7 years. And then there's a fewer number of patients, less statistical power, but the hazard ratio is still under 1 out to about 10 years, but significant out to about 6 or 7 years. So showing for the first time that the benefit of DAP really does extend much longer than we had appreciated in a contemporary trial with good background therapy. As well presented as an ESC late breaker, not yet published, is this analysis looking from Themis at peripheral outcomes. I mentioned there was a significant reduction in MI, a significant reduction in STEMI, a significant reduction in ischemic stroke. There's also a significant reduction in limb ischemic events. So all arterial territories showing a benefit. Now, that's one side of the equation. What about the other side? Abbreviating the duration of DAP. Well, the Twilight trial was a well-done, well-powered study that took patients who tolerated a 3-month period of DAP without ischemic or bleeding events, so a carefully selected population. But one could say, like happens in real life too, you always see what happens to patients with that initial period of DAP. And then they were randomized to continuing DAP or dropping the aspirin essentially and continuing ticagrelor. And the bottom line was that the primary bleeding endpoint was cut in half, essentially, as well as BARC3 or BARC5 bleeding, which was also cut in half, a statistically significant finding. Not surprising, though, if one thinks about it. Of course, if you drop aspirin and compare that against placebo, of course, there should be less bleeding, but still nice to see the magnitude, at least in relative terms, but even in absolute terms. Now, what about ischemic events? That was the real question. And there, the good news was there was no difference in ischemic events, at least for the duration of follow-up here in the trial. This isn't testing 5 years of DAPT versus 3 months. It's testing that more intermediate range, but still for that, there was no detectable benefit. Though I'll point out in Themis, for example, there was really not much benefit in the first year after randomization in terms of reduction in ischemic events. So this doesn't really preclude that there would have been benefit in those patients that tolerated DAPT without a bleeding or other complication, that had the trial continued longer, that some benefit of DAPT may have emerged. Of course, that's speculative. And there are many trials now that support this concept of abbreviated DAPT, TICO, STEMI, Smart Choice, Smart DAPT, are all studies that conceptually support abbreviating the duration of DAPT, in some cases with ticagrelor, in some cases with clopidogrel. So the concept is really quite sound. One thing, though, I'll mention about ticagrelor, whether it's DAPT or monotherapy, is something that I hope is on the horizon. This is data from the phase 1 program for a ticagrelor reversal agent, a monoclonal antibody specific for ticagrelor that binds to it, that immediately reverses ticagrelor's effect in a sustained fashion for as long as the infusion is continued. There's a phase 3 trial that's been launched, and enrollment's already started in the US, Canada, and Europe. So hopefully, if the data in actual patients undergoing emergency or urgent surgery or with bleeding, if the data look good and match what was seen in this healthy human volunteer study that I'm showing on this slide, well, then we might have a way of dealing with patients when they come in with a ticagrelor-related bleed or need emergency surgery on ticagrelor. And if that's the case, it really would then distinguish it, say, from prasugrel, or for that matter, even clopidogrel or aspirin. Now, as I wrap up here, what can we do in terms of figuring out who should be on what? Well, there are a bunch of different risk scores out there. I happen to like the precise DAPT score. The paper itself is published in The Lancet, but this is available for free as an online calculator. And without going into the specifics of how to do it, if you want to go to the free online calculator, I'll just mention that there are 5 elements in it, but I think a couple of the elements are particularly important. So age and creatinine clearance, that raises the risk of bleeding, as everyone knows, but it also raises ischemic events. So that's kind of helpful, but maybe not super helpful. Increased white blood cell count just means the patient's sick. But the 2 things that I think, even if one isn't using a risk score, that is really useful is prior bleed. Nothing predicts a future bleed like a prior bleed. Even if it's a reversible cause, like a gastric ulcer that gets clipped by your gastroenterologist, still, the fact that that patient bled means that they're a high risk of bleeding in the future. And if they have colonic arteriovenous malformations or things like that that predispose to recurrent bleeding, well, if they're already having bleeding in the past, they'll probably have even more if you intensify the duration or intensity of the antithrombotic regimen. Anemia is another powerful predictor of future bleeding, or poor tolerance to a major bleed. So if patients are anemic or thrombocytopenic or have a history of prior bleeding, I really think twice or thrice before intensifying the antithrombotic regimen or just continuing long-term DAPT. There's also different ways of gauging the risk of patients. This is some work, including from Dr. Palmerini, examining angiographic risk factors, showing that for patients with multiple high-risk procedural characteristics, if you're treating long lesions, lots of metal bifurcations, et cetera, if a lot of that is present, well, that's the sort of patient that really is going to benefit from longer duration DAPT, whereas shorter duration DAPT may be more appropriate for that simple type A lesion, to the extent any of us are really treating those anymore. So this is one way of using the angiogram, but it's not just the amount of metal, it's also the amount of underlying coronary artery disease that drives this relationship. And this is another way, it's not a risk score, it's just sort of my own way of eyeballing the patient and figuring out whether you should go with longer or shorter term DAPT, and perhaps even shorter than 6 or 3 months. And I think the major drivers are, did the patient have an acute coronary syndrome or not? Did they have spontaneous plaque rupture? If they did, well, the risk of it happening again is high, especially if they're going to keep smoking, especially if you can't get their LDL under control. But even if you do, that risk is still higher than the patient with stable coronary artery disease who has never ruptured a plaque and provoked an ischemic event. If a patient has high risk of bleeding, as I just mentioned, there you might consider shorter durations of DAPT, because usually long durations of DAPT backfire. The bleeding ends up trumping over time the ischemic risk. So if you know they're at high risk of bleeding, probably best to abbreviate that duration of DAPT or keep the intensity to a minimum. In patients with diabetes, renal dysfunction, heart failure, previous stent thrombosis, not due to non-adherence, PAD, their longer durations probably make sense. And then the anatomy matters. Again, as I said a minute ago, if it's a short, simple lesion, maybe there it makes sense to go shorter duration DAPT. If it's long, complex underlying disease, a lot of metal going in there it may make sense to go longer. In terms of approvals in the US, and I think this is less relevant to the rest of the world from a regulatory perspective, but still insightful given how carefully the FDA reviewed data, clopidogrel, ticagrelor, prasugrel all have a variety of different indications across acute coronary syndromes and prior MI, as you can see here. But in June of 2020, in the middle of the pandemic, so not everyone necessarily in the US is even aware, ticagrelor, based on Themis and Themis PCI, did get a broad approval for stable high-risk coronary artery disease, not just with diabetes, as we studied in Themis, but even in those without diabetes, because the FDA rightly realized that Themis enrolled diabetes because we wanted high-risk patients, have high event rates, but the lessons learned really more broadly apply to high-risk, high ischemic risk, low bleeding risk patients. And in terms of meta-analyses, I'll just share one that was very recent where we pulled all the different short and long-term ADAPT data. And the bottom line was for ACS patients in general, longer than 12 months was the way to go. And for patients where it was elective PCI, shorter durations, less than 6 months, seemed the best net clinical benefit. Finally, I'll just mention this concept of dual pathway inhibition, not dual antiplatelet therapy, but an antiplatelet, largely aspirin at a low dose, plus rivaroxaban 2.5 BID, vascular dose rivaroxaban, a quarter of the usual atrial fibrillation dose. This has been studied in COMPASS, which was a positive trial which led to the approval of vascular dose rivaroxaban in many regions of the world. This analysis just came out at the end of 2020 in Circulation, examined those patients from COMPASS with no prior PCI or with prior PCI. Now, we excluded from COMPASS patients with recent PCI. If they had an indication for DAPT, they were not included in COMPASS. So these are more remote PCIs. But the point being that this strategy of double antithrombotic therapy here with a reduced dose NOAC, not dual antiplatelet therapy, it's basically the same message with a reduction in ischemic events over the long term. This was true in those without prior PCI as well. So this isn't a story about the stent. This is a story about the underlying plaque. And in the case of COMPASS, both those with prior PCI and without prior PCI also had lower mortality when randomized to dual pathway inhibition versus aspirin alone. So more data supporting this concept that 2 antithrombotics is better than 1. So to conclude then, in ACS patients, I believe the data still support at least 12 months of DAPT if there's no bleeding that's occurring while the patient's on DAPT. If the patient, however, is at high bleeding risk, has a history of prior bleeding, bleeds while they're initially on DAPT for a month or 3 months, well, there I think abbreviating DAPT to 3 months, or if it's really a bad situation, a month, is reasonable based on randomized clinical trials that I mentioned. At that point, I think ticagrelor is preferred based on trials like Twilight, but I think clopidogrel monotherapy is a reasonable option if ticagrelor is unaffordable or unavailable. And in patients, if they're post-MI based on Pegasus, have diabetes based on Themis and Themis PCI, if they have complex stenting, which means complex underlying disease as well, there I would consider longer durations of DAPT. And at least in the US and Canada, the ticagrelor label has been updated based on Themis and Themis PCI for CAD, and provides a rational basis in select patients for continuing longer-term BAP. But really, we've got to integrate the patient's ischemic risk, the bleeding risk, and keep an eye on them as they are on dual antiplatelet therapy to see how well they're tolerating, and revise strategies as needed in that individual patient. Well, thank you very much for your attention. Hopefully this review of some of the old and some of the new with respect to antithrombotic therapy has been useful. Thanks so much.
Thank you. Thank you, Deepak. It was a brilliant review on antiplatelet and antithrombotic treatment. Time for discussion now. We have a wonderful panel, as you saw, Dr. Virmani, Dr. Duk-Woo, Dr. Palmerini, Alaide, Chieffo, Davide, Capodanno, so, and our two lecturers. So please feel free to ask a question. I can begin with one to Robert. Robert, speaking of about DEB, it seems that it's promising, but probably doctors must learn to the old good time of balloon angioplasty. And they cannot be used like delivering a stent. Can you comment on that technique for using properly drug-eluting balloon?
Yeah, I think, like you say, it is promising. We do need more data, particularly in the de novo space. But we should remember, when we think back to the systemic or the systematic adoption of stents a few decades back, the randomized trial data probably wasn't that compelling for a systematic approach. And the two limitations at that time were possibly related to dual antiplatelet therapy not being quite as good as it is now, and the fact that plain balloon angioplasty was limited by restenosis at a later point. And we've addressed both of those issues, arguably, with drug-coated balloon combined with contemporary DAPT. So there is reason to believe that it's a sensible approach. You're right to highlight that meticulous attention to detail at the time of angioplasty is important. Of course, you know, it's something that people need to be focused on in terms of the device that they use for thorough lesion preparation. But I think we have made a lot of progress in terms of tools for lesion preparation, and I think that we certainly do a good job on this nowadays.
Could I ask a question, Robert?
Yeah.
Okay, Spencer, you are muted. Yeah.
My question to you is, why is it that PCI does not work in diabetic patients? And I think it's important for us to understand how to treat and what is the underlying mechanisms why diabetes is such a problem.
Yeah, so I mean, as I alluded to, I think there's two elements. Number one, of course, is the well-known diffuse disease burden and the rate of disease progression. And that's certainly a large component of the benefit that you see with bypass surgery compared to PCI in these patients. And I think that's understandable from first principles. But there does appear to be relative resistance to sirolimus at the mTOR receptor. And I think there's a good basic science rationale as to why maybe we need to get higher doses of sirolimus or sirolimus analogs into the vessel wall, and dedicated stents or dedicated technologies to increase the sirolimus level at the vessel wall probably makes sense in view of the relatively wide therapeutic index that we have with rapamycin analogs.
I think it's more a problem of thrombosis than I think just simple. Of course, inflammation plays an important role, but I think it is really the coagulation problems that occur. Because from what we've seen, why is there diffuse disease? The reason for the diffuse disease is because there's thrombus burden is much greater in these patients. And I think, Deepak, you would be able to answer some of those questions. The basic questions of why diabetes, overall patients with diabetes don't do well.
Yeah, I actually agree with what Dr. Virmani said. I was thinking the same thing. I think, you know, everything Dr. Byrne said is correct in terms of PCI and its advances. But I think part of the problem, and this goes back even to some work Dr. King had done years ago with the yeast trial and so forth. I think part of the problem is when you bypass a diseased vessel, you bypass that entire proximal vessel, all the sort of plaque there that might misbehave, that might rupture, that might thrombose. So if the prox LAD plaque ruptures and there's an occlusive thrombus, it matters less if there's a patent lima to the mid LAD. That might be a small end STEMI, but it's probably not going to be a fatal event. Whereas in that patient without a bypass, even if their LAD is stented in the mid portion, that proximal plaque could still cause trouble. So I think the two keys there in the patient with diabetes is aggressive medical therapy to try to prevent that plaque rupture, whether it's things like statins or icosapent ethyl, or in those with diabetes, SGLT2 inhibitors and GLP-1 agonists, and those sorts of approaches. And then I think it's sort of a seatbelt or an airbag where plaque rupture is still going to occur even under the best of current medical therapy. And there, the patient with diabetes has a higher risk of that happening. Any patient with that plaque rupture could have that happen, but that risk is even higher, both the risk of the plaque rupture and then the ensuing thrombosis. And that's why in the patient with diabetes, I think that gap between CABG and PCI, perhaps even medical therapy, is even higher. And there, the combination of aggressive medical therapy and aggressive antithrombotic therapy, I believe, would narrow the gap between PCI and CABG. So I don't know if that really addresses the point you raised, but that's at least my thinking around it.
I think we're getting less interested in diabetes for some reason. I see more and more attention paid to long-term follow-up and the comparison of diabetic patients. One recent one from the Syntax experience, which of course is a bit of outdated technology with the stent that was used and the drug that was used, but there's a recent observation by Patrick and the group looking at Syntax, sort of claiming that the diabetic subgroup in that did not that much different from the surgery group if you follow them long term. There was an earlier advantage of surgery, as you point out, but then over time they seem to get worse. As I watch people selecting cases, I don't see as much attention. We used to concentrate a great deal on the heart team agreeing that the diabetic patient would aim much more towards surgery than we do now. Is this a trend? Are we getting more comfortable? Maybe we're getting better stents. Maybe we're getting better anti-platelet therapy, or is the presence of diabetes, particularly if they're not insulin dependent, still a major factor, Deepak, in decision making? Or Robert, what do you think?
I think it's a great question. I think it really is a provocative one. At least myself, it's still a factor. I always factor in, diabetes, LV function or LV dysfunction, and the presence of those things does, if all else is equal, tend to bias me towards surgery. But the anatomy really matters. I mean, I think, if someone has more diffuse disease, a lot of proximal disease, there I would still favor surgery. One could say maybe a high Syntax score is one way of it, but I more often use the eyeball test. But, I think if there are multiple bifurcations, CTOs, yeah, we can open it with current PCI technology, but the data, at least when one meta-analyzes the data, still does support a benefit, including lower mortality with CABG versus PCI for multivessel disease. The Syntax analyses you refer to, of course, are selected patients where the anatomy would be suitable more or less for both. But I think even there, for folks that have lots of plaque burden, proximal disease, bifurcations involved, if they're a good surgical candidate, CABG is the way to go. Now, if they're not a good surgical candidate, have to worry about their stroke risk, their recovery time, if they're frail. So I think there are a lot of different issues that come into it. If the goal is, alleviating symptoms in an 80-year-old, I probably wouldn't go with CABG. If the goal is to increase longevity in a 55-year-old, there I might consider CABG more strongly.
Yeah, I'll just add very briefly in the interest of time. I think it still is an important factor, at least in our practice. We consider it at the time of our MDT discussion, and I think it weighs heavily on the decisions that we make. I know in terms of risk scores, if you look at the Syntax 2 score, I don't think it had diabetes in it, interestingly, when you were looking at PCI versus CABG, and that may be because other factors outweighed it when they looked at all the variates that they considered. But I think for us, the short answer is it still has an important impact on our decision making.
Sure. What about the panelists? You got some questions?
Yeah. Yeah, about can you continue on the Robert Byrne lecture about technique, other technical point to address? I don't know, lithotripsy, Alaide, Davide.
Yeah. I mean, I have a question apart clearly mentioning new devices and, for example, lithotripsy, as far as I know, just got also FDA approval. Clearly is another tool that you can have in the cath lab. But also something else, you touch the imaging and you touch also the functional assessment that clearly changed our way to do PCI. What about now coronary physiology? Because this is an argument that come back and forward in our cath lab and now is fashionable again, because we have all these patients coming to our attention with angina, and in the end they have non-obstructive coronary artery disease, and what we do. So at least now we had, a positional statement from EAPCI on INOCA, on the S guidelines. It was touched the importance also of this evaluation. Which is your thought about that? And which is actually your strategy in your cath lab? When you have this kind of patient, do you further go studying coronary physiology, CFR, MR? Do you do acetylcholine testing?
Yeah, I'd say I would agree with you. It's a very topical issue for discussion. And actually, I would say we're kind of changing our cath lab practice at the minute. We're listening to the experts in this area. And heretofore, we hadn't been measuring coronary flow reserve or IMR in patients who would come to the cath lab with normal coronary arteries or no clear cause for the chest pain. But the emergence of consensus documents and joint up thinking to these patients has given us some important take-home messages. And I think there is a reason to suggest that it has therapeutic implications in terms of the medical therapy that we offer these patients downstream. So I'd say we're changing. We're not probably as systematic as we should be in doing these procedures, which tend to take longer and occupy more of our cath lab time, but it's something that we're doing in selected patients, and I think it'll become a bigger part of practice. The second part of your question maybe relates to pressure wire guided PCI. I mentioned it in my conclusion slide, but I didn't go into it in detail. It's intuitively attractive when we're faced with patients with diffuse disease patterns to try to pick out where we have the greatest step up in pressure gradients and to treat those first and see how the patient goes. And I think that is something that we're doing more and more. Do we have compelling evidence? I would say it's not compelling to tell us that that's the way to go. And there are issues around these measurements and the accuracy of these measurements and the limitations if you've got downstream disease. But I think targeted PCI based on pressure drop is something that's going to become more of our practice in the future.
We have about 5 or 6 minutes more. Are there questions from the panelists?
Yes, I have a question for Dr. Bhatt. So first of all, congratulations for your very nice presentation. So the question is about 1 year dual antiplatelet therapy. Why is that? Because most of us still recommend 1 year dual antiplatelet therapy in the majority of patients, and because it is still recommended by European and American guidelines. So in support of 1 year dual antiplatelet therapy, you mentioned 2 important studies, PCI Cure and PCI Credo. But you also mentioned that 1 year dual antiplatelet therapy was compared with just 1 month dual antiplatelet therapy. And if you do an analysis on how the events were distributed through 1 year, it is apparent that most of the benefit was within the first 3 months, but no more than 6 months. And this is also consistent with all the studies that have been done after, comparing 6 months versus 1 year dual antiplatelet therapy, in which no benefit was apparent. So to me, the summary of evidence suggested that if the patient is at high risk of bleeding, you go short, 1 month, whatever is the bleeding risk of the patient, or if the patient is at high risk of ischemic events, you go very long. So it's not a question of time point, but of time divergence between the two antiplatelet therapy. And in this regard, I don't see any role for 1 year dual antiplatelet therapy. What is your opinion?
You know, I think that's a beautiful way of summarizing the data. I mean, I agree with what you said and the way you said it. You know, the 1 year is just anchored in the guidelines right now. So that's why, you know, many quote a year, myself included. And it also, the reason the guidelines are anchored on a year is because what the initial trials did, as you mentioned, CURE, Credo, for that matter, you know, even Plato did 12 months, Triton did 15 months. But even there, much of the benefit in absolute terms was earlier on, not later on. So I think you're right. That is the real issue. I don't think that there's something magical about 1 year. But as a practical point, many physicians see the patient at 1 year in follow-up. So it's often the case they'll be seeing a patient at 6 months, at a year. So it can be a natural point to reevaluate a patient. But I think you're right, scientifically and clinically, it makes sense if somebody's a really high bleeding risk, a month of DAPT with current stents is probably fine, especially if you've imaged it and are happy with the stent sizing and apposition and that sort of thing. 3 months is a reasonable sort of compromise position for patients that are high risk, but not super high risk of bleeding. You know, I think elective, simple PCI, to the extent anyone is really doing that anymore, 6 months seems to be reasonable. But I think for all others that are not at highish bleeding risk, who have either ACS or very complex anatomy / complex procedures, I mean, I tend to go longer than a year and reevaluate periodically because the patient's getting older, their ischemic risk might be increasing, but they're getting older, their bleeding risk may be increasing out of proportion. They might develop, you know, diverticulosis, colonic arteriovenous malformations as they age. That would change the risk benefit. They might develop a tendency to fall, hit their head. That might change the benefit. You know, they might stop smoking. That might markedly reduce their ischemic risk. So I think you're quite right. It's not really just a simple either or. And for some patients, shorter is clearly better. For some, longer is, I think, still clearly better.
No, sorry, I would not finish this session before having some comments from our host, Dr. Duk-Woo Park, and from Davide Capodanno, who is here, very quiet, but I'm sure he has comments to do also. So please, Park.
Okay, David, you first.
No.
Oh, thank you very much. No. I enjoyed the 2 lectures. Of course, it's really a pleasure to listen to what Robert and Deepak say on these topics. Well, maybe in the interest of time, I can share a reflection that I made while I was listening to some of the trials that were shown, and particularly 2, TICO on one side and PCI Cure on the other side, because there are 20 years between the one and the other, and the 20 years of progress and innovations as shown by Robert. So the point is that even the trial design is changing, because PCI Cure is a sub-analysis of a large powered trial for ischemic endpoints, and it met the primary endpoint, while TICO is powered to show a reduction in bleeding or an improvement in a net benefit. So it's becoming more and more difficult to find a difference between strategies, but we have also to acknowledge that what we are looking for is changing over time. 20 years ago, we were looking in improvement in ischemic endpoints, and now we are looking in improvement in safety, in bleeding. So we have to acknowledge that in this field, everything is a moving target. Control groups, standard of care is changing, and this is why also trial design has to evolve accordingly.
No, thank you. It was a wonderful comment. Do you add add something, Dr. Park?
Yeah, so this is some general comment. I think this session combination is a very precious combination. It's difficult to see elsewhere. Dr. Spencer King, really first pioneer in United States, have much time with Andrea Krunchik and Dr. Morice. So first trial, the CYPHER, historical Ravel trial, Dr. Renu Virmani, you are civil pathologic pioneer for drug-eluting stent development. My question is some general question I think most of the audience want to hear is from your expert in the world in the future direction or perspective we should to go. And how do you, some general comment in this question to Spencer or Virmani and Maurice?
So, Spencer,
well, I can tell you that where to go is a lot harder than where we've been in terms of prediction. I'm reminded of the talk that Robert gave and showing us the evolution and how things have changed so much. And it reminds me of a golf analogy. It's once said that Bobby Jones, the famous golfer from many years ago, saw Jack Nicklaus playing golf, and he said, "This is a game with which I am unfamiliar." And I think that if Andreas Grunzig came back now, he would say, interventional cardiology is a game with which I am totally unfamiliar. It has evolved so much. But having said that, we have to remember that Mr. Bachman is still alive. And so there may be, we go back to the future with some things like a drug-eluting stent and things of this sort. But we must keep our minds open and think about the future. The past is interesting, but the future, of course, is much more important.
Yeah, and I will have some concluding words on this session. Let's say very interesting to see, as you say, the senior of interventional cardiology confronted to, I would not say confronted, working together with the rising star of our specialty. It's a real pleasure, and it's, I would say, continuous work. We all together continue the improvement for patients' sake, both in terms of PCI, moving technologies, and treating better the patient with drug. So I think that I must acknowledge everyone that took part in this session. Acknowledge a lot TCTAP and for inviting us all to this session, and I wish you a wonderful course because we are at the beginning. Yeah.
Thank you. Wonderful, great.
Thank you.
Stay safe. Get vaccinated.
Bye.
Thank you.
Yeah, great. Yeah, appreciate this wonderful session. Thank you.